I'm Sarah Teasdale. I'm a primary care pediatrician at Children's Hospital. And there's quite a theme today of, is this too loud? I'm very loud. There's quite a theme today of patient engagement and reaching patients where they are and reaching outside of our clinic walls. And I hope to share an experience today that adds on that. This is Celeste, or who I will call Celeste. She has sickle cell anemia, and she was 4 years old when I met her. She had recently immigrated to the United States from West Africa. Now, Celeste had a complicated introduction to this country. Within her first 3 months in the United States, she was bounced back and forth to the hospital despite being previously healthy in Africa. And she had 2 admissions for acute chest, which is one of the most dangerous complications of sickle cell disease, the leading cause of mortality in these patients. She had multiple blood transfusions, she had IV antibiotics, and in less than 3 months, she ranked up about $60,000 worth of hospital bills. So Celeste's new hematologist suggested she go on a medicine called hydroxyurea, which is actually a chemotherapeutic agent that's used to reduce the complications of sickle cell disease. And I met with Celeste and her mom in primary care clinic soon after this medicine was prescribed. Celeste's mom looked at me askance, and she said, I don't trust this medicine. I don't like it, and I'm not going to give it. And she said she didn't trust the doctors. Now, I'm not a hematologist, but I knew this was, given the course of her disease, a really dangerous decision. And I couldn't convince her. I was one of those doctors she didn't trust. So I went out on a limb. Just happened that one of my dear friends is a 38-year-old woman with sickle cell disease who actually grew up in West Africa. And despite struggling with this disease, she's a professional pastry chef, she's a sickle cell ambassador, and she's a mother of a set of healthy twins, just Celeste's age. And so I asked Mom if I could introduce them. And I said, would you like to talk to somebody who's lived with this disease and who's doing well? And Mom took the number. And all I know is that they talked. I never asked what they talked about. Interestingly, Celeste got on hydroxyurea a few weeks later, and she's been on that medication since. She's not had any further complications, and other than a few co-pays, she has not accrued any healthcare dollars. And that was almost 2 years ago. She's now a chubby 6-year-old. So, for those of you that don't know, sickle cell is an awful disease. It affects primarily African Americans in this country, about 1 in 400 African American births. And 1 in 12 Black Americans is a carrier. Now, the numbers aren't huge. There's only about 100,000 people living with sickle cell in the United States. So we're talking about a small subset of patients. We don't actually know because there is no national data collection center for this disease yet. So it's a small number, but these patients are not cheap. We spend about almost $500 million. Again, these are estimated numbers because we don't have a national registry. But the average child with sickle cell, in a recent study that came out of BMC, said that they cost about $11,000 to $14,000 per year. Now that doubles basically per decade as they get older. The average lifespan is in the mid-40s, and then triples, and then quadruples by end-of-life care. Over 70% of these patients are on public health insurance. Well, the problem with sickle cell disease that has been shown by many is that it's an isolating disease, the hallmark of which is chronic, debilitating pain. And we have made amazing medical advances in this disease over the past century since it was discovered. But yet we've done very little to keep these patients from suffering in a dangerous silence. Very little to increase their quality of life. Now, my experience with Celeste was a very powerful lesson for me. So I decided to set up a mentor project. What if we could get a few of these mentors, adults living with sickle cell, for other patients in our clinic? Could that affect quality of life, engagement in care, and eventually cost and healthcare outcomes? So the first thing I did to set up a mentor project is I set up a leadership team. And the leadership team included a lawyer and a friend of mine who's a longtime sickle cell advocate, a nurse from our clinic, and most importantly, 4 women with sickle cell disease. And these women had very strong ideas, quite different from my own, about what we needed to do to meet this population's needs. And they said, don't make it medical, don't script what they're going to talk about, just make the connections and let them talk to each other. Now, as an academic physician, this completely freaked me out. But I went with it. Now, we're still in our early stages, and unfortunately, but to be expected, we've met with numerous obstacles. We sent out informational letters to our families. Only about 30% of them arrived. So we called them all. More than half of the numbers weren't working, were disconnected, were totally wrong. Now, this is the information the hospital has to contact them. And most unfortunately, though, because we did this as an IRB feasibility study to start, most of these patients who emphatically accepted this idea when it was discussed with them with a trusted provider in the clinic, once they were called by a research assistant that they didn't know, they got distrusting and declined. Now, despite this, we've actually moved forward and we've trained our first group of mentors. It hasn't been easy. Mentors have been hospitalized. One actually completed her training on a morphine drip in the hospital. We're very proud of her. Now, the women on my sickle cell committee keep reminding me at every time when my face falls, do not give up. This solution is not going to be quick. It's not going to be easy. And it's going to take thinking outside of our clinic walls, beyond ourselves as healthcare providers, to that extensive resource of all those other people in our patients' lives who are there to help them and support them. And in terms of where we're going, now that we've got some of these mentor patients assigned, we're going to follow them. And once we have a period of time of them together, we're going to relook at the quality of life, patient activation and engagement in care, and then eventually over a longer period of time, we're going to look whether this, has any effect on health outcomes. And, this idea of a grassroots outreach is obviously not new, as, to what my colleagues' amazing work will attest. But the idea of disease-specific mentors in this particular subset of very isolated, extremely vulnerable patients hasn't been tried. And we've at least got an N of 1 to say that the rewards are potentially great, both with regards to health outcomes, with regard to cost, and also just maybe with regard to improving the lives of these kids who are suffering in silence. Thanks.